privilege to have our former Department of Health Secretary. Dr. Pauline Jean Ubial has led an extensive career in public health service for 29 years. Starting as a volunteer health worker in Kidapawan, Mindanao, she worked for 13 Department of Health secretaries tirelessly and passionately, rising up from the ranks to be Secretary of Health in 2016. She graduated Doctor of Medicine from the University of the East, Ramon Magsaysay Medical Center, Philippines. She holds a master's degree in public health from the UP Manila, where she is currently an adjunct professor at the Health Policy Department of the UP Manila College of Public Health. Her vast experience in the country's health condition have led her to be a leader and champion of kalusugang pangkalahatan with advocacies in women and children's health, breastfeeding, blood donation, tobacco control, healthy lifestyle, and mental health, among others. Her numerous notable designations are Founding Program Manager of the Centro Sigla Movement, the Quality Assurance Program of the DOH, and the Founding Manager of the Women's Health and Development Program in the DOH. With her expertise in women's health, she was named as the DOH Gender and Development Focal Person. This afternoon, she will deliver a lecture on After the ECQ, the New Normal for Women's Health. We are honored to welcome Dr. Pauline Jean Ubial.
Thank you. Thank you, and good afternoon, everyone. Yes. So I'm honored to be part of this webinar. I'd like to congratulate the Philippine Obstetrics and Gynecologic Society, headed by the President, Cristia Padolina, my former teacher at UERM, and of course, Dr. Ronaldo Santos, and the hosts, Joanne Aguinaldo, Marinela Abat, and Ana Marie Saballero, and all the other speakers. So let me just share my slides with all of you. Okay, can you see my slides?
Yes, ma'am.
It's clear.
Yes,
okay.
After ECQ, the new normal.
Okay, so because I'm a first speaker, I prepared a few slides about the current situation. So this is my outline, the milestones, the situational analysis, database policies and norms, and experiential learning, and what the future holds. Actually, I'm now a volunteer medical frontliner at the Quezon Institute Mild COVID Isolation Facility in Quezon City, as well as in the Red Cross Molecular Laboratory in Mandaluyong. So I will share some of my experiences in these two agencies. So we recall that this particular pandemic started in December 2019, where there was a very severe pneumonia noted in some of the people in Wuhan, China. And then they cannot differentiate the virus or the pathogen that was causing this very severe pneumonia. It was identified only on January 7, 2020, that it was a coronavirus, and it was then named novel coronavirus. The first case of the Philippines was 4 months ago, January 21, from a case who came from Wuhan, China. And then 2 more additional cases were detected, close contacts of the first Wuhan case. And sometime at the end of January, the World Health declared the novel coronavirus as a public health emergency of international concern. And it was labeled as the coronavirus 2019 in February. Then we had no cases in the Philippines in February, there was increasing cases in Wuhan, China at that time. But on March 4, after a lull of more than a month in the Philippines, a fourth COVID case was identified. And this particular case was without travel history. And then by March 8, there were already around 24 cases of COVID-19, and many of these cases had no history of travel or exposure to a known COVID case. Therefore, the public health experts in our country asked the president to declare a red alert sub-level 1 due to the possibility of local transmission of COVID-19. And then March 11, just a few days later, the WHO declared COVID-19 as a global pandemic. At that time, it has spread to over 100 countries around the world. And by March 13, the President, Duterte, declared Luzon under community quarantine. And then on March 16, the President again elevated the declaration of community quarantine to an expanded community quarantine, which we now term as ECQ. So that's where the term came from. And at this time, the death toll in other countries was higher, now higher than the death toll and cases in China. The cases in China by March was going down, whereas the cases in other countries, particularly Italy and the United States, were all going up. Okay. So right now, 4 months after the first case was detected, or 5 months after, we have 215 countries and territories of the world reporting COVID-19, and more than 5 million cases have been identified. And I think right now it's 350,000 deaths, 340,000 deaths are now recorded. So death rates in the United States, Russia, and Spain, and 10 other countries have exceeded that of China. Case fatality rate is still at 3.5%, and total death is around 40,000 today. So as we can see, that the whole world is actually responding to this pandemic, and it has affected greatly many of the countries. And here in the Philippines, I believe that there's a lot of report that we have flattened the curve. Okay, so right now, as of May 20, we have 12,900 confirmed cases, an estimate of about 200 to 250 cases, new cases a day. And the main question is, are we flattening the curve? Well, most public health experts are saying yes. There was a peak in the cases sometime on March 31, where the highest new case recorded was over 500. But still, we are detecting 200 or so cases per day. And incubation period is at 7 to 14 days. New cases will come out every 14 days if transmission is happening. So this is the latest graph. As you can see, the very highest peak there is 500 or so cases on March 31. And then we saw a decline in the number of new cases per day. And we're right here at the very end, seeing that there is a steady decline every 2 weeks. Okay. So we all know that the nature of the disease, this is the one that is causing a lot of alarm, because 81% of cases are either asymptomatic or mild, and therefore they usually don't know that they have the disease, and they don't seek medical attention, and they are not isolated. The 81% of cases. Only 14% have severe disease or pneumonia, and 3.4% have very severe disease or acute respiratory syndrome. Now, this is in contrast with the MERS-CoV and the SARS, where severe disease was the norm, so that at least most of the cases were identified and hospitalized and isolated. That's why SARS, which is a coronavirus, and MERS-CoV, which is Middle East Respiratory Syndrome coronavirus, did not go into pandemic proportions because most of the cases are severe. So what we have now is the challenge to isolate and identify all positive cases so that we can cut community transmission of the coronavirus. So as we move from ECQ to GCQ, or General Community Quarantine, I think that we continue to identify strategies to flatten the curve, to stop viral transmission. So that is the strategy now, is T3 or 3T, that is test, trace, treat at the moment. So the government is actually moving up the testing capacity across the country. So we're actually reaching about 10,000 tests per day at the moment. But we haven't reached the 2% of the population that is what WHO is recommending to actually get a clear picture of the epidemic curve in the country. So the longest incubation period is 12 days. So we usually isolate symptomatic patients or those that tested positive for 14 days. And vulnerable and elderly with pre-existing comorbidity, and those that are immunocompromised. Okay. So the question now is, are we flattening the curve? Are we identifying the, it's no longer PUI and PUM, but it's suspect, probable, and confirmed COVID-19 cases. Isolate them and prevent viral transmission. So I think after ECQ, the main norm that we will be implementing as a country and as a global population, global community, is really social distancing. So standards have been identified, and this is based on infection control or infection transmission data, that we need to at least maintain 6 feet apart between persons. So probably the new norm in our clinical practice and even in public health is that the doctors and staff will have to maintain 6 feet distance amongst their patient and amongst the staff of their clinic and hospital. So what does that mean? Meaning that we can no longer accept, let's say, walk-in patients. They have to be like by appointment, and we have to ensure that in any given time there will be no crowding in our clinics, and the available seats are well spaced and patients are well spaced, so that after each patient you have to disinfect or clean the clinic or the space where the patients actually are treated and like examined. So it's very tedious now. Like after ECQ, you used to see about 20 patients a day probably in your clinic. And for us in public health, like when I was in Kidapawan, I was seeing about 100 patients a day. That's the norm in public health settings. Everybody is crowding in a small space. Maybe after ECQ, that will no longer be acceptable. So for private sector, probably about 10 patients in a day. Each patient coming in 30 minutes after the last patient to give you time to actually clean or to dove your PPE and don a new PPE. And for public health, maybe like uh, uh, all patients are by appointment. No one should come in or be walk-in patients. And I'm thinking that in public health, like what we've done in many of our programs, like delivery of vaccines, will now be door to door or going from house to house, rather than the patients coming in to a very limited space in the health center. Okay? And part of the new norm is actually wearing masks. We used to not wear masks in our clinics, and even the patients and the staff should be wearing masks. Practice hand hygiene, alcohol, foot bath in our clinics, and the works for infection control. There are also norms like using disinfectant air filters, UV lights, and the like. So I think setting up a private clinic will now be more expensive because you have PPEs, you have disinfectants, you have other gadgets that you need to put in place. And even the plastic that you have to put between the patient and the staff. So probably the main question, I think all of you already know the social distancing and infection control that's written on this slide. But the main question here is that, should we test all pregnant women that come to our clinic? Or, well, in public health, many of my colleagues are saying this is not cost effective. Like testing, we did a study on testing pregnant women for HIV/AIDS, and because of the low prevalence in our country, it's not cost effective to test all pregnant women. You test only the high risk. So in this case, I think that's something that POGs and obstetricians will have to decide on, whether to test all pregnant women or just to have a position that all patients that come to your clinic are actually presumed positive already, so that you have to ensure universal precaution. Okay, so I think all of this I've already mentioned. So what does the future hold? We need to stop community transmission at this point. It's not yet happening, but we're very happy about the ECQ flattening the curve. Like our health system, our hospitals right now are not overwhelmed with severe cases. And hopefully this will continue. We have to continue our cough etiquette, our hand hygiene, and all that. And we see in this century that flu has become the pandemic that we encounter, like the 1917 to 1918 Spanish flu, which was estimated to have killed about 50 to 100 million people, or 3% of the global population. If we did not go into ECQ, I think that was the estimated number of deaths for COVID-19. But it's now flattening the curve because most countries have gone into ECQ. And we see a pattern that every so often, like after 50 years, there was the Asian flu. Then after that, after only 20 years or less, there was the Hong Kong flu. And then we had SARS in 2004. And then we had MERS-CoV in 2012. So the interval between possible of global pandemics is getting shorter. So after COVID-19, we as public health experts feel that we have to be ready for the next global pandemic, which is just around the corner and not happening after 100 years. So that's the current situation. And I think this is my second to the last slide. We've recorded many pandemics in global history, but the last 5 happened only in the last 130 years. And the worst of that pandemic was the avian influenza seasonal flu that happened in 1918. Okay, and there are deadlier diseases, as I mentioned. SARS is deadlier. Its case fatality rate is 15%. MERS-CoV is 35 to 40%, and Ebola. But I think diseases wherein the presentation is more severe is actually less likely to cause global pandemics or high number of cases, because you can readily identify and isolate those who get the cases because they are severe and they get hospitalized. So finally, thank you for listening. We must prepare for global pandemic. Be Girl Scouts and Boy Scouts ready ever to face this as the new normal. We can defeat COVID-19. I believe the Filipinos are very resilient. And of course, we need to pray and stay healthy. Okay, stay home. Thank you.